The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everybody, and welcome back to the FlightBridgeED MDcast. I'm your host. My name is Mike Lauria. I'm an emergency medicine, EMS, and critical care physician with a special interest and focus in critical care transport, and currently working actively as a flight and retrieval physician. So today's episode is one I've been meaning to do for a while, and it's on lung protective ventilation, and asking the question, are we really protecting the lungs? Very interesting, and I know that everybody's aware of this, that mechanical ventilation is a double-edged sword. It is a technique to keep people alive and maintain oxygenation and ventilation, but it comes at a pretty significant cost. It can be very damaging to the lung parenchyma itself, and sometimes it can actually make things worse. So ventilator-induced lung injury, VILI, is absolutely a thing that we see all the time in the ICU, and something that we strive to the best of our ability to prevent. Now, I think we should mention that in the context of this discussion, what I'm mainly talking about today, is going to be lung protective ventilation in the setting of acute respiratory distress syndrome. And why I specifically say that is because, yes, there are other things that can cause some of these problems with poor lung compliance and whatnot. But I'm really just going to focus in here on ARDS, because especially in the wake of COVID, this is something that has really come to the forefront yet again, and is something that I think flight crews deal with on a regular basis, and is important, because if we intervene on it, if we know what we're doing, if we're careful about it, we can minimize that secondary ventilator-induced injury and help our patients out. It's also important, and I contextualize that in the setting of ARDS, because for a long time, we were very binary. We talked about obstructive ventilation for obstructive pathology, so COPD and asthma, and then essentially everybody else should have lung protective ventilation. Everybody else should be ventilated at 6 cc's per kilo, and we know that's not the case. So we have the PREVENT trial and a host of mounting evidence that in patients without ARDS, it is absolutely reasonable for their comfort and for other physiological benefits, that is totally okay to actually ventilate them a little bit more. Going up to 8 cc's per kilo is totally reasonable. So you don't have to be totally draconian about it unless you're an ARDS. So I think it's important, and I know we've mentioned this on a couple of other podcasts regarding ARDS, around where a lot of this stuff came from. And it was really in 2000 after the ARMA trial came out. So that was the trial that was conducted by the ARDS network that looked at lung protective ventilation. And I think it's important to mention that, remember, they looked at 12 versus 6 cc's per kilo. And 12 was much closer to the standard volumes that patients were getting at that point. But that's a pretty big difference. That's essentially like twice the volume. So it still remains unclear exactly what's perfect, 6, 7. And we know now that in non-ARDS patients, you can probably liberate it up to 8 or so. But we still don't know the exact answer. Is 5 better than 6? Is 5 better than 7? And under what circumstances? But what I think did come out of that trial is our number one goal. So the first thing I think we should be looking at, for sure, our protocols should reflect this. And it is, I think, good evidence-based practice that should be a quality metric, is maintaining a plateau pressure less than 30. I think it's also important to mention, based on the ARMA trial, remember that they were actually looking at less than 25 to 30, 30 being the absolute cutoff, where there was a significant increase in mortality. But we should probably be trying to aim for a little bit less than that. And I hate always using like single number cutoffs, because it's always a little bit different. There's always some gray area. So in my brain, I think about keeping it less than 27 to 30. I always think about like less than 27. That's a green light. We're doing pretty good. We're okay. We're in a relatively protective area. 27 to 30 is like the yellow light, like, hey, caution, I should be concerned. Think about doing stuff. Greater than 30, I probably got to take action because there's a really good chance we almost certainly are inducing injury. And I think that under those circumstances and looking at that study, the answer is what is common practice, and I think is very appropriate, is decreasing the tidal volume or ventilatory volumes. If you're in pressure control, that would be decreasing the inspiratory pressure, delta P, or pressure support above PEEP, or whatever your ventilator calls it, so that you're not causing harmful distension to the lung. Okay. I think it's also important to mention that based upon sort of the parameters of that study and good physiological evidence, or good physiological data and some other evidence, that we should probably be going down on volume, but the general sort of stop point there is about 4 cc's per kilo, and or maintaining a pH greater than 7.15. And that, of course, is in there, as many of you know, because if you're going down on the tidal volume, you're going to be dropping your minute ventilation. You drop your minute ventilation, the amount of CO2 that you blow off with the ventilator is going to go down, and is going to go up. The amount of CO2 you blow off is going to go down. The PaCO2 is going to go up, and your pH is going to go down. So those are sort of the fundamentals. Yes, we should be trying to keep the plateau pressure. We should be keeping our tidal volumes to 6 per kilo or less. We should be keeping our plateau pressure to less than 30. And if it is above 30, the way we should be doing that is going down on the tidal volumes to a limit of about 4 or 7.15. Okay. So that's, I think that by this point, I'm probably reiterating stuff that you already know, and is common practice in critical care transport around the globe. Now I want to talk about some other parameters, and there's 2 more in particular: driving pressure and mechanical power. And these are newer concepts, especially the concept of mechanical power, that I want to talk about. Before I get into the discussion, I do want to mention a couple caveats. First, there is really good biological plausibility behind these ideas. The papers that have recently been published and the observational data that's been presented is pretty robust. It's pretty good, and it makes really good sense to me. However, and this is a huge however and caveat, we've definitely gone wrong, or we've misstepped in critical care, emergency medicine, and critical care transport, pre-hospital care, when in the past we've sort of jumped on board with the new hotness, and we've ignored the fact that there's not good randomized control trials, there's not good data in an area that could potentially have it, and we've sort of we've gotten on the bandwagon a little too soon, and that has not been to patient benefit. We've later come out into actually X, Y, and Z didn't really work. Great biological plausibility, good observational data. Actually, when we do a randomized control trial and take out all the bias, it doesn't work. So that's the big caveat to these 2 things. It also means that from a medical director perspective, I would not codify these things. I would not make crews do these things, document these things, or put these in any way, shape, or form into a quality metric yet. But it's worth thinking about as intelligent, open-minded clinicians that are interested in physiology. So without further ado, the number 2 thing I think that we should be evaluating for lung protection is driving pressure. I think it's really interesting that things over time, and I've always had this feeling in the back of my mind, like really just a simple number, just the plateau pressure, static compliance, or that's representative of static compliance of the pulmonary system. That's all we need. It's really that simple in such a dynamic and heterogeneous disease. Just keep it under 30 and we're good to go. Well, that may not necessarily be the case. The interesting thing about driving pressure, and to define it mathematically, it's the difference between the plateau pressure and the PEEP. So you get your plateau pressure, you subtract the PEEP, and that is essentially your driving pressure. And what this is it's essentially a surrogate for transpulmonary pressure. It's a surrogate for the amount of pressure that's required to deliver a specific tidal volume at a given lung compliance. So why is that sort of important and attractive as an idea to me? Well, it's more customized and representative of the individual patient's transpulmonary pressure or the pressure that we're using to deliver that breath. Remember that the way we always come up with tidal volume, the way we've been taught to do it, the way it was done in the ARDS net trial was based on ideal body weight, essentially with a focus on the patient's height, right? Because at a given height, if I put on 60 or 70 pounds, if I sit in the ICU or sit at base just eating donuts and cake all day and put on like 50 pounds, my lung size doesn't change, right? So it shouldn't be based on your weight, but rather your ideal body weight, which is largely based upon your height and your skeletal structure, which houses your lungs, right? However, the disease process of ARDS in particular is heterogeneous, both within the lung itself and over the course of time. It changes. It is different for every single patient. So just basing things on their height and therefore their ideal body weight may not be the best way to evaluate their tidal volume. Maybe looking at this driving pressure, looking at this pressure to basically scale the tidal volume breath to not only that person's size, but their lung pathology and their lung compliance is a good idea. Now, this idea of driving pressure and the concept, the mathematical measurement is not necessarily new, but it really came to the forefront in 2015 when Amato and his colleagues published a really fascinating paper in the New England Journal that basically demonstrated that retrospectively, when you look at a bunch of patients, the best predictor of mortality was not plateau pressure, but rather was driving pressure. And above, interestingly enough, 15 or so, as far as the driving pressure is concerned, that was the biggest predictor of mortality. That makes sense in my mind and has, I think, substantial physiologic plausibility, because if you think about it, the sicker someone's lungs are, the less compliant they are. And if they're really sick and really stiff, heavy, wet ARDS lungs with their, pneumocytes sloughing off of their alveoli and compressing everything's, and closing down those alveoli, not being able to exchange gas. It makes sense that a stiffer, sicker lung, those patients are more likely to die. So the question becomes, especially since a lot of this data is retrospective, are they more likely to die because they're just sicker and therefore their driving pressure is higher? Or is there a causal relationship? If their driving pressure is higher, we are injuring their lungs more and we are causing them to die more frequently. That, I think, is the big question. So should we be aiming for a driving pressure in particularly, like, again, codify that, make people do it, indicate that that's a quality metric for good mechanical ventilation? I think that is yet to be determined. So why should we care about this? And, well, how do I actually use it? I think there is a role for this, a more precise role that we should be looking at now and perhaps considering in terms of titrating the tidal volume down. So perhaps even if their plateau pressure is less than 30, let's say 27 or 28, and I have a PEEP of 12 dialed in, that would mean that their driving pressure, 28 minus 12, is 16. Perhaps, even though their plateau pressure is less than 30, I should still back off on the tidal volume a little bit and try and get that driving pressure down. in the absence of other reasons why we should not lower their tidal volume, it may be a good idea and it may be helpful for the patients. So that, I think, is how I use it. And that, I think, is a reasonable application of it. And I think, furthermore, if you really think about it, it can be a wonderful tool. And a number of authors have suggested this, but again, no good RCT prospective data to really say that this should be a standard of care. We should do it for everybody. Is PEEP titration. So, for example, let's say you have that same patient, and their PEEP is 10, and for easy math, we'll say that you're giving them 6 cc's per kilo, and their driving pressure is 16. Let's say again, so their plateau pressure is 26. And what may be reasonable to do at that point is say, okay, well, maybe 10 of PEEP is not enough. Maybe it's too much. Let's try and increase the PEEP. Now, which may seem kind of crazy. You're like, hey, your driving pressure is already 16. Why would you want to go up on the PEEP? Well, here's why. So let's say you go up on the PEEP, and their plateau, you go up on the PEEP by 2. So you change their PEEP from 10 to 12, and their plateau pressure goes from 26 to 25. Their driving pressure just went from 16 to 15. Well, what happened? And in fact, I'm sorry, their plateau pressure went down from 26 to 25. Their PEEP went up to 12 that you just programmed in. So their driving pressure actually went down to 13. So you might say, well, how does that happen? What is going on? Well, by increasing the PEEP, if you recruit new lung, you open up a whole bunch of alveoli. Now you have much more space, much more real estate for that given tidal volume breath that you programmed in to go into. The plateau pressure comes down and the driving pressure comes down, and you just made an effective change that brought their driving pressure and plateau pressure down by opening up and recruiting more lung. Now, let's say the opposite happens. So you actually go up on their PEEP from 10 to 12, and their plateau pressure goes from 16 to 30. Or excuse me, their plateau pressure goes from 26 to 30. So you just put in 2 cc's, or excuse me, you added 2 centimeters of water of PEEP, gone from 10 to 12. Their plateau pressure went up by 4. Their driving pressure went from 16 to essentially 18 at that point, right? Because their plateau pressure is now 30. So their driving pressure went up. Their plateau pressure went up. That means you're probably over-distending the lung. You've probably hit potentially the optimal PEEP. You may have to even go down on PEEP, but by adding more PEEP, you're not helping the person. You're probably over-distending their lungs. So I think that's a reasonable, safe practice at this point, but we still have some more research to do in that area. There have been recent investigations. This is why I'm always cautious about making these changes to practice or teaching people some of these new things, that there's a handful of new investigations that have shown that limiting driving pressure and limiting tidal volume are essentially similar. So if you just keep their tidal volume to less than 6 cc's per kilo, that essentially it's the same out in terms of patient important outcomes or patient specific outcomes as if you were limiting the driving pressure to 15. That kind of does make sense because that driving pressure or that pressure change is related mathematically to the volume, right? So if you go down on volume, you go down on pressure at a given lung compliance. However, I think we still have some more work to do in terms of, should this be a standard of care? Should we be doing this on every patient? And should we be making changes constantly and pushing hard to get below that plateau pressure of 15? I will tell you at this point that I think we should consider it. And one of our goals should be to evaluate, do they have a driving pressure that's less than 15? And if not, consider making some changes in certain patients. Okay. So that was driving pressure. Let's go to number 3. Number 3 is a really cool, again, very attractive, but not completely evidence-based or evidence, shall I say, proven topic of mechanical power. This is really interesting because as our understanding of ventilator-induced lung injury has become more nuanced and we think about it, right? Perhaps the injury that we're doing to the lung is not just a static measurement like plateau pressure. Perhaps it's not just a change in pressure or a reflection of a change in the transpulmonary pressure, but actually related to the total energy that is delivered to the lung over time. This is the concept of mechanical power. So it's the energy delivered to the lung over time, what might be what's causing the damage. And this was initially introduced by Gattinoni and some of his colleagues. There's some fancy math involved, and you may see about it if you Google it or look it up in the papers. People will use different equations to calculate mechanical power. And that is because depending upon how you do the derivation of the equation, it's essentially most of it's coming out to the same numerical value, but you can rearrange different pressures and numbers. And so you will see different formulas out there. Essentially what it consists of is understanding, yes, the tidal volume, but also dynamic features of mechanical ventilation, including the number of times you deliver that breath, i.e., if you're ventilating someone and giving them nice slow breaths at 20 times a minute, which very rarely are sick ARDS patients getting ventilated like that, you are delivering less energy to the lung over the course of time than you're trying to deliver those same breaths 30 times a minute. Furthermore, in terms of dynamic pressure measurements, it's not just a static measurement of plateau pressure that's included in the equation. It also considers the peak pressure, which to now we've kind of discarded. Many protocols and whatnot have not looked at this because we want to see the plateau pressure. So we want to see the pressure when there is a given volume that we hold in the lung, and what that lung, and as a reflection of lung compliance, we measure the plateau pressure. Right? What if it's more than that? What if it is actually how we deliver that pressure over time, a dynamic measurement with each breath? Maybe the peak pressure is in fact important. And therefore, especially in a volume control mode, maybe the inspiratory flow, the rate of flow, how fast we push that breath in, is also important. If we push it in nice and slow, that distends the lung nice and slowly, opens everything up slowly, maybe a flow of 40 liters per minute or 45 liters per minute. When we start going up to 60, 70, 80 liters per minute of flow, that increases the mechanical power. We're jamming that air in there faster. Perhaps these things taken in totality provide a better representation of what the overall energy that's delivered to the lung and how much damage we may be doing. Interestingly, I think this is very attractive from a physiological standpoint, and there is some interesting observational data. But again, we got to be really careful. Shooting for this may be challenging, and it may be kind of fraught with peril in the sense that there's a lot of pieces to this equation. Which pieces are more important? Is it really the inspiratory flow rate? Is it the peak pressure? Does the peak pressure in fact not matter? Is it really just overall what the quote unquote alveoli are seeing as that plateau pressure? Is it really more a function of rate? Is it really more related to how fast we're ventilating people? How many times per minute we're pounding this sick lung with these breaths? I don't know, and I don't think anybody knows for sure. There are some studies that do suggest that it's probably more related to the driving pressure. It's probably more related to that pressure change at a given tidal volume than the actual rate. But we still kind of got to figure this out. And so I think this is challenging to say, hey, we should absolutely, the thing that we should be looking at is mechanical power. Everything should be guided by reducing mechanical power. That I don't think we're ready to say yet. There are some studies that I think show very, very interesting studies that look at the relationship between rate and inspiratory flow, and how that can actually increase strain and cause significant increases with strain in the lung. Again, physiological studies. There are some other studies out there that I'll put in the show notes that look at mechanical power, and of course, it's associated with higher mortality. Again, we got to be careful how we interpret this, because is that higher mortality actually caused by higher rate? Is it caused by higher driving pressure? Can we just look at the tidal volume? Is that really what's doing it? Not sure, but not surprisingly, the faster we jam air in and the more times we jam air in per minute and the higher pressures we generate every single time we jam that breath in, not surprisingly, are related to mortality, at least when we look at it retrospectively. In some patients with ARDS, there are some studies that, again, have observed retrospectively there is a association with mortality when the mechanical power starts to exceed the 22, 23 range, which is very interesting. And there are some other studies that have looked at things like mechanical power and damage to the lung, or ventilator-induced lung injury with other scoring systems when it's above 22 to 25. There are some studies that have demonstrated, or at least I should say, have shown an increased association with mortality once mechanical power is above 17, as low as 17. And in patients on ECMO, again, retrospective observational data, but it does show a correlation, an association between increased mortality and a mechanical power above as low as 14. So if these patients are so sick they end up on VV ECMO, that inflection point may go down and be as low as 14. So what do we think we should do with this? Well, we may want to keep in mind that going down on or potentially limiting mechanical power to less than 17 to 22. Again, 17 in my mind, below 17 in a patient that's not on ECMO, probably being green, okay, we're delivering a reasonable amount of energy to the lung. 17 to 22, not quite sure, but maybe in that zone of higher associated mortality, and above 22, probably so much energy being delivered every minute that it could be damaging and seems to be associated with increased mortality. Of note, I'll put the equation in the actual show notes so you guys can see it, but you can do various derivations both for using assist control, volume control, or pressure control modalities that will give you this. But it's basically a function of minute ventilation, peak pressure, PEEP, and inspiratory flow, at least in the in volume control. And then in pressure control, looking at the respiratory rate, the exhaled tidal volumes, and the PEEP and the delta P, or the inspiratory pressure. So those are the variables. I'll put those equations in the show notes, and it's difficult to go over them in somewhat of a podcast. But what I get asked is, now that we're thinking about lung protective ventilation in a much more nuanced way, and I have sort of I won't call them pillars because I think that's too strong a word, but my considerations for lung protective ventilation, moving beyond just looking at a plateau pressure and keeping things at 6 cc's per kilo. I will at least share with you my current practice as I explore some of these ideas. Again, not maybe all of them ready for prime time, but bear with me. This is my practice anyway. The evidence-based suggests, and in fact, I think we should be, and step one for me is making sure the plateau pressure is less than 30 centimeters of water. So start them at 6 cc's per kilo, 30 centimeters of water or below. That, I think, is an absolute yes. We should be doing this all the time. And now my practice is I will look at that. And if it's below 30, especially if it's below 27, if it's below 30, that's okay. If it's above 30, if the plateau pressure is above 30, I will begin to titrate the tidal volume down to about 6 cc's per kilo, or a cutoff as we're going down the tidal volume to a lower minute ventilation, a cutoff of a pH of about 7.15 to 7.2 to get the plateau pressure below 30. That is step number one. If it is below 30, so let's say it's 26, 27, 28, something like that. Then I move on to the next step and I'll look at the driving pressure. So again, this is where it gets into the realm of not super evidence-based, but I think something we can consider looking at the driving pressure. Okay, so now let's say I have a PEEP of 10. My plateau pressure is, let's say, very sick ARDS patient, 26. Again, going back to that example, I'll look at it and say, okay, so yes, their plateau pressure is less than 30. Good, that's good. But their driving pressure is kind of on the high side. May they benefit still from a lower, may they benefit still from A, being recruited, and B, perhaps a lower tidal volume. So the first thing I'll do is I'll go up on the PEEP a little bit. So you go up from 10 to 12. What happens to the plateau pressure and what happens to the driving pressure? If the plateau pressure comes down and I've recruited long and the driving pressure comes down, great. If the plateau pressure stays the same, but I went up on the PEEP, my driving pressure came down, awesome, great. Driving pressure's down, plateau pressure's below 30, move on. If you went up on the PEEP and the plateau pressure went up, so it goes from 26 to 28 with an increase of 2 of PEEP, and the driving pressure now is still 16, or it goes up even more. So let's say it goes from a plateau pressure of 26 to 30. You increase the PEEP by 2 and the plateau pressure goes up by 4. Now I know I've overdistended the lung. I'm going to do 2 things. One, I come back to that nice PEEP of 10, and then I start going down on the tidal volume. It's also not unreasonable, and some people have suggested, well, leaving the PEEP of 10, right? And then coming down on the tidal volume. But preferentially, I'll say, I think by increasing the PEEP, I may have overdistended things. Come back to the PEEP of 10, and then start to dial down on that tidal volume. So you come down to the PEEP of 10, plateau pressure is back to 26, driving pressure is 16, come down on the tidal volume a hair so that their driving pressure is approaching or below 15. Again, within the limit of a 4 cc per tidal volume breath and or a pH of 7.15 to 7.2. Cool. So now let's say we have come down on both of those. So we made sure our plateau pressure is less than 30. Lung protection there. Also making sure we're coming down the driving pressure to less than 15. Awesome. So we came down the tidal volume a little bit. Now I go to the mechanical power and say, okay, again, this is a new and evolving concept, but is it reasonable to address other factors that may decrease the overall energy delivered to the lung? So let's say, for example, we came down, or we had that PEEP of 10. We tried titrating it up, didn't work. Our driving pressure was 16. Our plateau pressure was 26. I came down on the tidal the tidal volume from 6 cc's per kilo to 5.5 cc's per kilo, and now the plateau pressure is 14 and change. Awesome. Okay. I'm still ventilating that patient because remember, we came down the tidal volume from 6 cc's per kilo to 5.5 cc's per kilo, and often we have to make adjustments to the rate to maintain a minute ventilation when we drop the tidal volume. Cool. Now I look at the mechanical power and I say, okay, we've messed around with the PEEP, we've messed around with the tidal volume. Are there other parameters? What is the mechanical power? If it's clearly less than 17, cool. Don't mess with anything. Perfect is probably enemy of good. If it is higher than 22, so let's say 25 or 26, are there other parameters I can adjust to at least bring it down a little bit, maybe get it below 22, at least in the 17 to 22 joules per minute range for mechanical power? So I'll look at the rate, and I'll look at the inspiratory flow, and I'll look at other stuff and say, can I get these down a hair? Can I reasonably get these down a hair to try and decrease the amount of energy that's delivered to the lung every minute? And so let's say that I'm ventilating this person at a rate of 30, or let's say 32. and their pH is 7.3. So they're a little acidotic. And we were basing this on trying to keep their pH normal. Well, maybe this is a patient that I can allow some permissive hypercapnia and say, well, what if I came down on the respiratory rate to 28 instead of 32? I allowed for some permissive hypercapnia. So drop the rate, drop their minute ventilation, come down on their inspiratory flow a hair, making sure their I to E ratio is still good and all that other stuff for my respiratory therapists out there. But you come down the inspiratory flow just a hair, maybe say from like 60 to 55 or something like that. Come down just a hair and then see what happens. Did their mechanical power come down? Is it closer to 22 or below 22? Check a gas and make sure that their pH is still above 7.15 to 7.2. And let's say in this case, it's like 7.26, 7.27. So they got a little more acidotic, but we're allowing that in this patient who's otherwise appropriate for some permissive hypercapnia. And we've decreased the total power that's being delivered to their lung. So 3 steps: look at the plateau pressure, look at the driving pressure, and consider the mechanical power. Absolutely, positively should be limiting tidal volume to 6 cc's per kilo and plateau pressure less than 30. Considering the driving pressure, but this still needs a little time to get validated and I think proven as a concept we should be shooting for. But unless we're otherwise doing harm, maybe we should consider it. And then mechanical power. Again, not strong RCT data, but reasonable to consider. Are we delivering too much energy to this patient's lung? Is it reasonable and otherwise not going to harm them to actually dial back a little bit, perhaps on the rate, perhaps on the inspiratory flow, to try and decrease the overall energy that's delivered to their lungs? So some thoughts on more advanced and more nuanced lung protective ventilation. Some things like driving pressure and mechanical power do need a little bit more science and evidence to support them, but perhaps things as wise and intelligent critical care transport clinicians we should be thinking about. That's all for today's episode. Thank you guys so much for tuning in. Please take care and fly safe out there.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.